Dr. Aga is coming to us from San Antonio. She's the Chief of Informatics at San Antonio Metropolitan Health. She's an epidemiologist and data scientist with expertise in public health information, chronic disease risk prediction, and science communication. She's going to talk to us about COVID-19 and diabetes, an intersection of chronic and infectious disease epidemic in South Texas. Thank you so much for allowing us to listen to your talk.
Thank you. Please let me know if anything, you can't hear me or anything. It's great to be here. I'm sad that I'm joining virtually. We had a little Arctic freeze, which I'm from Canada, so it's hilarious that, we consider that, but it's wonderful to be here. Looking forward to joining future sessions in person and traveling that distance. So today I'm here to talk a little bit about COVID-19 and diabetes. The majority of my presentation is going to focus on data from Bexar County in San Antonio. Bexar County is the county seat of the city of San Antonio. I serve as the Chief of Informatics, so we really work on acquiring, processing, disseminating data from more than 40 public health databases, some of which you'll see here today. And we really look to derive insight and basically facilitate data-informed decision-making for a lot of our public health outcomes and initiatives. And of course, South Texas and just Southern USA in general, diabetes is a really big one. So today I'm here to show you plenty of data. So this is a very data-oriented presentation, so hope you'll enjoy it. All right, it's not advancing. Oh, there we go. Okay, please let me know if you can not see my slides advancing. Okay, so diabetes in Bexar County, where do we stand? A lot of our slides will also compare the rate that we have here in Bexar County to what's going on in Texas. This is BRFSS data over the past few years that looks like the prevalence of diabetes based on the self-reported survey of diagnosed diabetes, according to the CDC BRFSS. And we can see that for the most part, here in Bexar County, San Antonio, the prevalence of diabetes is slightly higher among Bexar County residents compared to Texas overall, although it does seem to be converging. And thankfully, we have a lot of new 2020 data. But again, it's important to know that data collection may have been seriously affected in numerous ways during the pandemic, due to lockdowns and staff going home. So it's important to look at 2020 data with a grain of salt and making sure to not make any definitive statements about trends. We also care about diabetes hospitalization, and that's a pretty big outcome here in Bexar County. And of course, this is people who were hospitalized, inpatient hospitalization for diabetes, presumably due to complications. And the graph on the left shows that in Bexar County, we have consistently a higher rate of diabetes hospitalization compared to Texas overall. The graph on the left, the right, shows you the rate differences between males and females. And we see that males in Bexar County, and probably the trend in many other places, over the years, it shows consistently that they have a higher inpatient hospitalization rate as a primary diagnosis here in Bexar County. And of course, this is the pediatric endocrinology group. Data on hospitalizations and mortality is, of course, for diabetes quite limited. What we're interested in is incidence data, which we currently don't have. But here's a look at diabetes hospitalization in pediatrics. So the graph on the left shows males for females overall for pediatrics. And we can see that the rate is pretty much the same in males and females. Of course, this does not discern type 1 versus type 2. And the graph on the right breaks it down by age group and also by male and female. And you can see that the majority of the kids that end up in the hospital for diabetes, it's more in the 10 to 17 age, 10 to 17 age range for this pediatric group. And here's some trying to discern between type 1 and type 2 diabetes. Of course, what's really important to say here, and I know there are people during this presentation, colleagues that I work with, that are working really hard on documenting and emphasizing the alarming increase that is happening in pediatric type 2 diabetes. Of course, the numbers are going to be very small for hospitalization at this time, but it's important to note that we want to keep an eye on these trends as we increase in type 2 diabetes at younger and younger ages. This is an important thing to think about when we think about undiagnosed diabetes or complications that arise from it at younger and younger ages as the type 2 increases in our youth group. So the graph on the left shows type 1 diabetes. Of course, this is much more common, and you'll see that the rate numbers are a lot higher. There is some fluctuations in data, of course, with small numbers, but overall, the rates between males and females, I would say, is similar based on this data. And then on the right, again, very small numbers, so the fluctuations are expected. But again, we can see some of the rates here for example, in 2018 for females, it was about 10 cases per 100,000 population that were in the hospital, were admitted as inpatients in the hospital. And then, of course, across the life course, we also think about diabetes mortality. This is data from CDC Wonder, which allows us to document the underlying cause of death and the leading causes of death in our place of interest. The little table on the left shows where we stood in 2019 for the leading causes of death for Bayer, for Texas, and USA. And for reference, I've highlighted in that diabetes was the 7th leading cause of death in 2019. And you can see here that in Bexar County, our age-adjusted mortality rate is notably higher than the Texas rate and the US rate overall. So this really speaks to the burden of diabetes here in South Texas. And on the right is the leading causes of death in 2020. And of course, we'll see that the 3rd leading cause of death was COVID-19. And interestingly enough, in Bexar County, the rate was higher than from the US overall, but not higher than the overall age-adjusted mortality rate for Texas. So as you could see in the 2nd and 3rd column, Texas took quite a hit for age-adjusted mortality of COVID-19 compared to the US overall. And here you could see that diabetes is still the 7th leading causes of death. And if you actually compare 6 and 7 on the left-hand side for 2019 to 7 and 8 on the right-hand side, you could see that it actually exceeded the rate for chronic lower respiratory disease. It actually bumped up one. Diabetes bumped up a place in the top 10 leading causes of death. So again, this is really telling of the continuous burden of diabetes here in Texas and South Texas. Then the bottom graph is something that I really like to show in order to put it in context for what's going on here in Texas. It's interesting that for the top 10 largest counties by population size, whether it be Tarrant, Dallas, Harris, and Denton, Bexar County actually has the highest age-adjusted mortality rate across these 10 largest counties. This is also a graph that shows the percent change in age-adjusted mortality from 2019 to 2020. And of course, you see at the top, interesting, it's Alzheimer's disease, but also you'll see that there was a 15% increase in age-adjusted mortality from 2019 to 2020. So again, when we're thinking about the burden of COVID and we're thinking about the onset of type 2 diabetes in younger and younger kids, it's really important to keep in mind that this is unfortunately the end result. We're seeing higher and higher diabetes mortality from diabetes. Now, of course, I work in the San Antonio Metro Health Department, and everything that we do, every piece of data that we collect, and every data-informed decision-making that we try to make has a social determinants of health perspective and what we call an equity lens. And this really speaks to the fact that, of course, many of you may know here, and of course, definitely in the pediatric group as well, you'll know that many of our top leading causes of death and many of our health outcomes in the US are very much characterized by social disparities, by racial ethnic disparities, and the interlink of them both. And this has been true for COVID as well across the country. And here in Texas, we've seen that the severity of COVID, severe illness from COVID, is very much characterized by racial disparities and by socioeconomic disparities. So again, what I've said basically is, how do social determinants of health manifest in Bexar County? Like in many other places, they manifest as socioeconomic disparities, they manifest as racial ethnic disparities, and they manifest as regional disparities. And of course, these disparities talk to each other, they're interlinked, often showing the same thing from a different angle. And the next few slides are definitely going to show exactly that with data. So here's a first example of socioeconomic disparities in diabetes prevalence. This data is Texas because the ones for Bexar County with smaller numbers. So on the left, you'll see that according to income category, the prevalence of diabetes decreases. And again, this is nothing new. It's very much established in the socioeconomic literature. Those with higher socioeconomic status have lower prevalence of disease. The same thing is shown on the right graph with education. You can see a graded dose-response relationship where higher levels of education afford higher protection from things, from chronic disease outcomes like diabetes. You could see that in the less than high school category, it's about 20% of survey respondents said that they have diabetes, compared to those with the college graduates, 8.7%. All right, and socioeconomic disparities are very much interlinked with racial ethnic disparities. And here is diabetes hospitalization data that shows just that. So these are some of our favorite findings from the hospital discharge data that we get from Texas. And these are inpatient hospitalization rates. You will see that on the left graph, the top line, the blue line, is consistently higher year after year. And that is the hospitalization rate for non-Hispanic Blacks in Bexar County. So again, you could see exactly the blue line at the top, the highest rates for non-Hispanic Blacks, followed the rate for Hispanics in the green, and then finally non-Hispanic whites have the lowest rate year after year. The graph on the right, interestingly, shows that it is Hispanic Latinos who bear the biggest burden of diabetic amputations in Bexar County. And I think this is a trend that will be seen in other places as well in Texas overall. So it's important to note that something about our Hispanic population, predominantly led by the males, we know by looking further into the data that they have a much higher rate of diabetic amputation rates for hospitalization. And then of course there's mortality. Again, we see clear racial ethnic disparities here. The graph on the left shows that across the board, and particularly for males, non-Hispanic Blacks have the highest rate for diabetes mortality. And again, you could see males versus females as well. So that middle bar graph is for non-Hispanic Blacks, and they have a higher rate. And the graph on the right shows that further broken down by race and ethnicity for 2020. And if you look at the one on the left and see that for non-Hispanic Black males in the purple, in the middle there, it's a rate of 39.9. Fast forward to 2020, and that middle bar graph in the purple for non-Hispanic Black males, that rate has now increased to 52.2 per 100,000 persons. So again, we're seeing increasing rates among our non-Hispanic Black population, as well as our Hispanic population. And again, when we think about racial disparities and socioeconomic disparities, they also manifest as regional disparities. That's because we can see, we've all heard the famous saying, your zip code determines your health much more than your genetic code, sort of a catchphrase that's caught on, but it really shows that regional disparities very much manifest as well in terms of the social disparities that we experience. Here are two maps by the census tract level. The one on the left is our equity score here in the city of San Antonio, which is created by our Office of Equity. It's an incredible score that's created by just mixing race and income data. And it has actually been used to mobilize a lot of on-the-ground work in terms of what regions and what neighborhoods to target information for. So we've done this a lot with using this map to understand high need areas for disseminating COVID information, for putting pop-up vaccine clinics. And it's really a great example of using equity to derive change in our actions in public health and in local government here. So you'll see that I've put a red line around the darkest colors in the left-hand map for places that have the highest equity score in the dark navy. And these are places that have the highest concentration of both people of color and low-income households. And what you'll see interesting is that it's a perfect correlation with the map on the right. which is the diabetes prevalence by census tract. Again, for people who follow data on census tract, this is an unbelievable correspondence. It's almost like 90% correlation, where the exact census tracts that have the highest equity score also are the places that have the highest prevalence of diabetes, according to CDC's 500 cities data. And of course, aside from a public health perspective on social determinants of health, we also care about a life course approach to health and disease. And of course, among a group of pediatrics, this is the most important because we know that the early life period has a particularly important influence on health and disease across the entire life course. So of course, you could see here, there's a little schematic diagram of what are the most important factors regarding chronic disease that start early in life, starting from the pregnancy where the mom is pregnant with the baby, prenatal care, nutrition, gestational diabetes, going on to early life, going on to youth, where nutrition, physical activity, and behavioral health and obesity are an important determinant of adulthood outcomes. And of course, adulthood, where the outcomes are seen as our leading causes of death. And again, it's important to point out that across the life course, all of these factors are characterized by socioeconomic, racial, ethnic, and regional disparities. Again, all of which are interlinked. So how do we look at a little bit of life course data? Well, this is not exactly causality here, this is correlation, but this shows correlation between, on the x-axis, data that we have from our Whitty Museum, of percent youth participants drinking one or more sodas per day. So this is really unique data that we have from a very cool model of a body adventure exhibit here in our Whitty Museum that collects this data from participants in a confidential, non-identifiable way, in a fun exercise exhibit way. And you could see here, every dot on this correlation plot is a zip code. And you can see on the y-axis that it is the diabetes hospitalization rate overall. We can see a very strong correlation here, where zip codes that have a much higher percent of youth drinking one or more soda a day also happen to have higher diabetes hospitalization rate. So it's interesting that this is a cross-sectional data, but you could see the link between youth and sort of overall adulthood. And I will admit that this can be better manifested if we map adult diabetes hospitalization rate, which we have done, and these correlations are just as strong. I just did not have it ready for this presentation. So again, a strong correlation between risk factors in youth and then diabetes hospitalization in adulthood. Here is another example. The kids in this part, and this is a few thousand people, so this is a pretty hefty sample size, which is why we can divide the data into zip code. You'll see on the x-axis that is percent of youth participants saying that engage in 1 hour or less of physical activity per week. And I think there's a typo here. It should be 1 hour or more. So sorry about that. But you could see that the higher the percentage of kids that say they engage in a lot of, oh, sorry, it's physical activity. Sorry, I thought it was TV screening. So this is correct. Basically, these are kids, for example, this zip code at the end, it shows that a zip code with a lot of kids who reported they have 1 hour or less physical activity per week. So very little physical activity. And you could see on the y-axis, diabetes hospitalization rate. And again, we do see quite a bit of a correlation here. Finally, I promised to speak a little bit about diabetes and COVID-19, which I think is going to be the central topic has been the central theme in many of the discussions, and a lot of work going forward with pediatric diabetes, is that diabetes, of course, is consistently recognized as a top risk factor for severe illness due to COVID-19. And here is some of our Bexar County data, which we publish monthly in our epidemiological reports from our COVID data response team. You could see on the left side that this is COVID comorbidities among hospitalized cases at a certain point in time. So among all the people that are hospitalized, of course, this is data that's also seen across Texas and the US. Cardiovascular disease coupled with hypertension and diabetes are the most prevalent underlying conditions. You can see up to 40%. The graph on the right-hand side sort of shows it in a different way. Among everybody, among all of the hospitalized cases that have a comorbidity, one comorbidity or another, 53% of those comorbidities are diabetes. So again, amongst all comorbidities, amongst the people in the hospital that have an underlying condition, Again, cardiovascular disease and diabetes account for the majority of those underlying conditions. And finally, this is data that we have just processed recently. This looks at basically the presence of diabetes and cardiovascular disease, either or, among COVID-19 cases hospitalized. This data is from June 2020 to May 2021. So please keep that in mind when you're looking at the numbers. We picked a particular time and point when there wasn't changes in case management system, and the sort of problems with data collection may have been released. So here we look at the graph on the left, and this is the presence of diabetes and or COVID among hospitalized cases shown by age group. And you can see that within each age group, starting very young, for example, in the 20 to 29 age group, 20% of those hospitalized had diabetes and or COVID. And of course, as you get older, the percentage increases. For example, among the 60-year-old group, 70% of those hospitalized had diabetes and or COVID. Now, if we look at among the non-hospitalized cases, of course, as expected, the percentage is a lot lower. Very little amongst the pediatric group who've not been hospitalized, but were just COVID-19 positive. And you can see that the gradient is a lot less here. Now, this looks at the prevalence of diabetes among those hospitalized. What if we flip it around and instead are interested in risk in a more prospective manner? So what is the risk of hospitalization among cases with diabetes and cardiovascular disease? This is data where we flipped it around and sort of wanted to look at what is the risk of hospitalization for those who have these underlying conditions. And you could see on the left-hand graph, this is percent hospitalized among cases with diabetes and or CVD. And again, what's interesting is that it's 9% among those 20 years old, 11% among those in their 30s, 17% among those in their 50s, and so on and so forth. So again, we could see that this is the proportion of cases with DM that were hospitalized. And then on the left-hand side, we could see the percentages of people that were hospitalized that did not have any underlying condition. So for example, among those in their 30s, only 2% of those without diabetes were hospitalized, without diabetes and or cardiovascular disease. So again, this interestingly looks at the risk of hospitalization among those people that had an underlying condition and caught COVID-19. And finally, if you take this last graph and plot it as a risk ratio, this is what we see. Basically looking at the 10 to 19 age group, for example, the risk ratio was pretty much 12 for risk of being hospitalized with diabetes or COVID-19. And of course, this is interesting because with the pediatric endocrinology group, I'm really interested to hear your thoughts on sort of the shape of this risk graph. So that is my final slide for presenting, but I do want to speak to the fact that I know there is a lot going on in the research group and the pediatric endo group at looking at the risk of developing diabetes, especially amongst the pediatric group after having caught COVID-19. And I know that CDC has recently published studies, and there were articles and editorials in the New England Journal previously about this, with some nicely designed studies that show an increased risk 30 days after COVID infection for diabetes for kids that got COVID. So there's a lot more people here that are an expert on that, and we can discuss it as a discussion, but for the most part, this is the latest data that we have on looking at the intersection of diabetes and COVID in Bexar County and comparing it to Texas overall.
Thank you so much, Dr. Aga. This is very interesting data and interesting presentation. I don't see any questions in the Q&A and in the chat. I do have a question, Dr. Aga. Will you be collecting data on the prevalence of diabetes in those in the pediatric population, those who received COVID vaccine versus those who are unvaccinated?
So unfortunately, right now, we don't have that data. We are working with partners, and they're actually in this presentation here, we're working with national efforts and here locally as well to document the onset of diabetes in the pediatric group and have information on COVID, but I'm not sure if that information is also going to include their vaccination status. I do think that some preliminary data is out, and people, colleagues in our Broward County, our doctors here have spoken to it, that it does definitely infer protection. But I'm not currently aware whether our collection efforts are going to include both vaccination status as well as the onset of diabetes.
I'm curious on this graph here, can we know anything about the breakdown of who has diabetes and who has CVD, especially in the childhood age range?
I could not hear the question. Someone's gonna have to repeat it.
Hey, just curious, do we know the breakdown of which of these patients, especially in the younger age groups, have diabetes without the CVD? Like, do we know what percentage of this is diabetes?
So I should have done that in order to sort of avoid small numbers. I think the majority for the kids are going to be diabetes, right? And type 1 diabetes, because
That's the assumption,
it's much more common than having cardiovascular disease diagnosed. That's a really good point. And I think it would be really good to look at these graphs just for diabetes, but I can almost assure you that for the pediatric group, the numbers are going to be very similar.
Yeah, it'd be nice to see that.
Absolutely.
I think we're all assuming they mostly have diabetes rather than CVD, but
it's mostly diabetes, right?
Thank you.
No problem. I can go over any of the slides if anybody wants to see them again. It was a lot of data and I went through it quickly, so please let me know if there's a more interest in just going to a certain slide and looking at it.
There's a question in the Q&A. I'm wondering if you can see that.
The higher amount of hospitalizations in the 10 to 11 year reflect hospitalization for DKA new onset versus COVID. So unfortunately, we don't have that information. No, so this data is from the COVID-19 database, which basically means that if a child was hospitalized for COVID-19, then their medical history was pulled up, and if they had diabetes, it was reported. So this is not looking at diabetes onset after COVID-19. This data is sort of data that comes from COVID-19 cases and the underlying condition that they have. We do not at the public health department have the capacity. I know our UT health partners are going to be doing this, but we are not currently collecting data on new onset diabetes after having caught COVID. That's why we have a lot of data collection efforts with our university systems that are preparing to do this work.
I do have a question. Do you have any plans of collecting data on the prevalence of type 1 and type 2 diabetes or occurrence of type 1 and type 2 diabetes in the pediatric population starting from the time we started the pandemic? So that would be early 2020 to 2022 to see whether there's an increased incidence of type 1 or type 2 in the pediatric population. And what has the impact of the pandemic to this population?
So I think my colleague Jane Lynch, I'm not sure if she's there in person, she's actually the one leading the very effort that you are speaking about right now. I'm not sure if Jane is there, but this was not a part of my presentation because I'm sort of only working as a partner in helping launch that effort. Is Jane Lynch, Dr. Jane Lynch there?
She's here.
Okay, let's have her come up and say a few things about this.
So I would like to reach out to all of PESTOLA with this topic. I just did a review of the CDC paper, and those two studies are very interesting. I think they're actually quite compelling for the databases that they use to show changes in the rates for diabetes. Definitely cannot tell type 1 from type 2. So that's a drill down that I think needs to be adjudicated similar to search in academic, pediatric, endocrine departments. And we need to own this and look at this. We are trying to put together a database. It's incredibly hard. That's why I was curious from Arkansas how they had done that, because we realized that whole CDC study was done before vaccines were available for children. I've pestered our infectious disease group, how long do antibodies last? 2 to 3 months. The ability to question families to know if their kids had COVID, realized many of the kids were asymptomatic. And if they did have it, odds are they weren't tested in the first 6 months to a year, because you would test one person in the family and presume it. A lot of the tests were not accurate. So I think the only way we're going to really figure this out is adjudicating type 1, type 2 in windows of time for incidence rates within same institutions. And the adjudication of type 1, type 2, everyone's heard me talk about, but it's so critical for us for figuring out our data. ICD-10s won't get you there, and insulin use won't get you there initially. So we've given this a lot of thought. And Dr. Aga's been amazing.
Thank you. You've heard it from the expert, though. There's a lot of excitement around this, especially after the release of the CDC article. And our Dr. Jane Lynch was on the local news speaking about this. So unfortunately, it's interesting to think about data collection. And currently, I'm no longer head of the COVID data unit. But one thing that I've been interested in is looking at, once now that we have the hospitalization, the vaccination data, how would the graphs that have shown about kids ending up in the hospital due to COVID show among those that had diabetes but were vaccinated, right? That is the ultimate question. Unfortunately, the way that our databases collect data, and this again, this talks, speaks to public health capacity, is our vaccination database is not linked to our COVID-19 case database. So unfortunately, the way that the data collection works right now, and I would be curious if any other place is doing it in a way where it would be possible, to look at, what percentage of kids that end up in the hospital having their diabetes status and also having their vaccination status, specifically for pediatrics. So unfortunately, we do not have that data in our case management system currently. It would be very curious to see. And of course, we would think that, vaccination would confer protection, even among those kids that have an underlying condition. I want to address another comment by Heidi. I am assuming the Hispanic population is a higher percentage of the population as a race, and thus the data will always have the Hispanic population be a higher rate. While this is a good point, yes, in Bexar County, approximately 60% of the population is Hispanic Latino, so we are a majority minority. However, everything that I've shown you in these graphs are rates. So they're basically adjust for population side by showing number of cases per 100,000 population. So it evens the playing field. In addition, they are also, the majority of the mortality data that I've shown you are again, age adjusted mortality. So they definitely basically adjust for the effect of age and how one place like Texas could lead to something else in a crude rate because the distribution of age would be different. So that's a great point, but unfortunately, the effects that we see here are not as a result of the Hispanic population being the higher proportion of the population.
Going back to data collection, Dr. Lynch, I totally agree with you. It's a daunting task to collect data, but maybe this is something that we can bring up to the PESTOLA to take this as PESTOLA project. Because it's something that I think will be very important for the future. We do not know when this pandemic will go away, how much impact it has in our population that covers the PESTOLA area. This might be a good NIH project. I don't know where to start, but we have to keep the conversation going. Thank you very much, Dr. Aga. Very interesting. Thank you for allowing us, giving us the opportunity to hear your data.